Hi, I'm Dr. Jared Gardner, and I'm here today with my junior dermatology residents and junior pathology residents and some med students, and we're going to go through some melanocytic lesion unknowns. So this is case one. What do you guys think about this? A little bit of lymphocytes in here. It's not as good as usual, but I know that you must know what's going on if you think about that. Yeah, there are lymphocytes here. What do you think about these cells? What kind of shape are they?
So these are spindle-shaped cells.
Spindle cells, good.
And with the Nevoid aggregates, I'm thinking like this could potentially be a Dysplastic melanoma.
Very good. Yeah, I mean, when you look at this, here, this looks like scar. I mean, a lot like scar. And that's the problem with Desmoplastic melanoma, is that they can really closely imitate scar or sometimes neurofibroma. The key here is that the context is really helpful, right? We're in very sun-damaged skin. There's a lot of solar elastosis here. And it's on the face or maybe the scalp. You can see big sebaceous glands, so face probably, but somewhere in the head and neck. And then the epidermis is really thin. And if we look around up here, in some areas, we may actually have a subtle melanoma in situ component. On this scan, it's actually hard to be totally sure. Like, I think those are probably melanoma cells, not lymphocytes, but it's very hard. But about half the time, you don't have any in situ melanoma in the setting of desmoplastic, which is kind of strange, right? So that's a good thing to remember, that you don't have to have in situ. So on a sun-damaged skin, especially on the head and neck, if you see spindle cells with background collagen, often with a little bit of blue kind of mucin or myxoid material between the cells here and there, see how it's got kind of a pink and blue, gives it a kind of a purple or lavender kind of color because of that intermingling of the myxoid or mucin plus the collagen. And then the cells are spaced out. If you see that kind of setting and you see lymphocytes and it's sun-damaged skin on the head and neck, always think of desmoplastic melanoma. So what immunostains could you do here to support the diagnosis?
S100.
Good, yeah. S100 or SOX10 would be the only really good stains. There are some other ones people have tried to use over the years to sort things out, but the mainstay of diagnosing this is morphology plus S100 or SOX10 to confirm the cells. MART1 or Melan-A, as it's also known, HMB45, those are going to be negative in a pure desmoplastic melanoma. See, here's mitotic activity, and this one's pretty bland. I mean, it's a scary one. Because these cells look a lot like fibroblasts or myofibroblasts in this case. A lot of times as you look around, though, you'll start finding more hyperchromatic, atypical pleomorphic cells, but they're often scattered, and the mitotic activity can be very sparse, and you really have to look around. Desmoplastic melanomas also really love to invade nerves, and see, they can also get kind of almost a slight fascicle appearance that gives them the appearance kind of like smooth muscle. Spindle cell melanomas, which is the kind of more cellular, ugly form, a type of spindle melanoma. There's desmoplastic and there's spindle. I've got a video on YouTube that explains, a little short video that explains the difference between those, because there is a behavior and treatment difference. Desmos, I'm sorry, what I was saying, that was spindle cell melanoma tends to really make fascicles and look like smooth muscle sometimes. All right, so these on a depth by depth basis, a pure desmoplastic melanoma, that means 90% or more desmo with 10% or less of the regular melanoma component in the dermis. Pure desmos behave better, have a better overall prognosis. I mean, there's still a problematic tumor, obviously, and a serious malignancy, but they have a better overall behavior than other types of melanoma of a similar depth. So these tend to be really, they can be locally aggressive and recur repeatedly. They often, on the scalp, they'll often grow down to, like, see, here's fascia. They'll often grow down like to the galea, like, or the periosteum of the skull. I've seen that many times. So this thing's gone all the way through. See, this all used to be subcutaneous, look. But now it's been completely overrun by tumor. Here's another, a little bit more clear example. I've got to post this for the Oregon Pathologists Association meeting I'm going to do tomorrow. So you guys are getting a sneak peek. This one's a little more crisp. Look at the lymphoid aggregates here. Nice lymphoid aggregates. much more obvious atypia here. See, the cells are really ugly and hyperchromatic, but see how they're still spaced out, right? They're spaced out by the collagen and the mucin myxoid kind of matrix in the background. So that's desmoplastic melanoma right here. I think this one had some neurotropism, if I recall. Ah, there it is. See? They love nerves. Desmoplastic melanomas do. Okay. Good job. Next case.
Big, large nodules kind of abutting the epidermis.
Good.
Separated from the layer of epidermis between them.
And even one down here in the deep dermis, too.
Looking at this, it doesn't really look that it's well connected to the epidermis. But the cells making up this nodule look pretty, like they're not behaving very well. Very swirly, big, lots of cytoplasm.
Okay. What do you think this is?
I think it's good for metastatic melanoma.
Okay, great. Yes, this is an example of metastatic melanoma. A couple clues that can help us here. The best thing in this case is that we see multiple lesions. So when you just have a shave of one of these nodules, it's much more difficult and problematic. You've got a nodule here, a nodule down in the deep dermis, a nodule up here. So this is either when you see a nodule of melanoma down in the deep dermis with no connection, that's almost always going to be a metastasis. Not necessarily distant metastasis. It could also be an in-transit metastasis or a satellite lesion, which is when the melanoma spreads to another site on the skin. It's either right around the site of the primary melanoma, but separated by normal skin. That's called a satellite. Or if it's further away from the lesion, between the lesion and the draining regional lymph node, then we call it an in-transit metastasis. For staging purposes, they mean the same thing. And they're kind of, more or less, they're the equivalent. A satellite or an in-transit metastasis is the equivalent of giving a positive lymph node to someone. For staging purposes, there's some more subtlety to it than that, but it's basically, so it's a real serious thing to have a satellite, okay, or in-transit met. But distant mets could be, like, say the person had a melanoma on the ear, and now this is on their chest. That'd be perfectly fine. So you have to know, to sort those out, you have to know, like, how far it is from the primary site. Again, when it's a nodule down here, then we know. But up here, this is when it can become problematic. Metastatic melanoma, when it's in the superficial dermis, tends to push up like this. It bulges up and pushes up against the overlying epidermis. So it's kind of pushed up. I think there's another one, the other one right over here. Same thing. You can, like, it's like a ball that's like been thrust up and pushed against the epidermis, and the epidermis kind of bulges up around it. Sometimes, usually the melanoma like this is just in the dermis and not in the epidermis, so the lack of an in situ melanoma component can be helpful. Although sometimes nodular melanomas particularly don't have an obvious in situ component, and also desmoplastic, like I just told you guys. But nodular melanomas sometimes seem to lose their in situ component. I suspect because they maybe ulcerate and then it heals over or something. But we do see sometimes where you don't see a good in situ component. So when it's just one lesion and there's not a good in situ component, it can be hard to prove that it's a met, and that's when knowing the history is really crucial. Here we knew the history, and in that case, it's easier. These melanoma cells are kind of a mixture of kind of epithelioid, rounded cells with big nucleoli and very atypical nuclei. And then other ones are kind of more spindly, like plump spindled cells. There's mitotic activity in here. So you could use your immunostains to sort it out. And per the notes on this case, I think there's somewhere where there's actually epidermal involvement. I guess a little bit right here. See, right here, the melanoma cells are actually starting to get up into the epidermis. So that can happen, and that's called epidermotropism. So sometimes metastatic melanoma and other metastatic tumors like carcinomas can metastasize to a site in the skin and then grow up into the epidermis and mimic melanoma in situ component. They make you think that it's a primary melanoma. So those without history are very, very difficult to prove and to sort out. So that's one where you really have to, the clinical situation has to help you when you have epidermotropism. But in this case, we knew the history, and also there are multiple lesions. And see how it's like a very circumscribed nodule and see how it's pushed up and almost getting a collarette? That's a real typical pattern for how metastatic melanoma grows. Good job. All right, so we just experienced a little technical difficulty and our whole slide imaging server crashed. So we're transitioning to some backup cases that I happen to have, and so hopefully that'll be good. So now none of you guys residents have seen these cases, so I'll just go through them. So here's let's say this is a 30-year-old woman with a 5mm black papule on the forearm. And this is what it looks like microscopically. Any guesses as to what this might be? And I can show you more pictures and see what you think. Here's what it looks like from lower power. And yeah, there's a melanocytic lesion with melanocytes. A lot of them down here. There's some up here also. Yeah, that's a good point. A good point to bring up is maturation. And I think maturation is hard to assess in thin lesions. The thicker a melanocytic lesion is, the more useful maturation is. When you only have, like here, like most of the stuff we're seeing, even these nests here connect to the reedy. So really the only dermal stuff is maybe this little bit here. So when you only have a few nests, deep into the dermis, it's really hard to tell, like, does it mature, does it not mature, right? So I feel like that's a challenging thing. So just like a lot of the things we talk about in dermpath, confluence and maturation, they all sound really good on paper, but in real life practice, sometimes they're easy on easy lesions, and on challenging lesions, they're really hard to evaluate. So here's a closer look at the cytology. Plump, kind of uniform, elongated, spindly to oval cells. A lot of pigment. And then here's an immunostain. This is T67, which is brown nuclear, and red MART1 immunostain. And so you can see, even from here, there's pagetoid spread in the middle of the lesion, which is scary, right? But look at the edge here at the periphery. Sorry, pagetoid spread in the middle of the lesion is what I meant to say. But at the periphery, look, it ends very, very sharply. It just like stops right there and right here. So this is an example of pigmented spindle cell nevus, also known as reed nevus. These can look kind of scary. They're probably related to Spitz Nevus. Some people think they are the same thing as Spitz or on a spectrum. I certainly think they have a lot of overlap. They have a spindled, plump spindled or elongated melanocytes that kind of run in elongated nests, and the nests can be arranged either horizontally, like this, where they kind of bridge across reedy, and when they have this pattern, they can really mimic, have a lot of similarity to Dysplastic Nevus. And then sometimes also, let's see, let me go back through to the area where it has it. Like in the middle here, sometimes they're vertically oriented and they kind of have this hanging down like the brown bunches of bananas. People sometimes use that as a buzzword for either reed or Spitz, again, because they have overlap. I think let me see if I have a closer view of that area. Oh yeah, here. So you can see here they're kind of coming down. Here they look a little more rounded. That's probably because we're getting some fascicles that are kind of coming towards us and are cut in cross section. So the cytology, they are plump, which is why I think when you look at a reed nevus, if you don't think of reed nevus right away, the first thought that you'll have is like moderate or moderate to severe kind of dysplastic nevus because of that kind of bridgy growth pattern. The things that help me to favor it to be a reed nevus rather than a dysplastic nevus is that, for one thing, you've got nice bridging, but look, none of that fibrosis. See, that this is very delicate collagen, whereas in dysplastic nevus, usually you get that kind of dense collagen or lamellar fibroplasia underneath in dysplastic nevi. And then if pagetoid spread to me is an acceptable finding in reed nevi and in Spitz, particularly in the middle of the lesion. At the edge, though, I want the lesion to stop abruptly and not trickle out onto the side. Reed nevi are usually small, very circumscribed lesions, and they usually are superficial. They're either all in the epidermis or just the superficial dermis. Most of the time, although I've seen some examples in books of like thicker, deeper ones, but in real life, in my experience in real life, they almost always are very thin kind of lesions like this. So that is a reed nevus, pigmented spindle cell nevus, and a lot of dermatologists that I know seem to excise these. I feel personally that that's optional. The main thing is making sure that if I can see the edges of the lesion, that's what I want, to be able to see that periphery, to make sure that I'm seeing the whole thing. Because otherwise, if you just had this piece here, you could get kind of worried about melanoma or something, right? So that's a good example of a pigmented spindle cell nevus of reed. All right, so this is a PowerPoint that a talk I've given before showing some various different melanocytic lesions. So this is kind of a list of them. So let's just look through them for the rest of our time here so that you guys can learn some stuff. So let's talk about, this is a congenital pattern nevus, and all the pictures from this talk, or almost all of them at least, are from my Survival Guide to Derm Path. So I have a conflict of interest, obviously. If you buy that book, I will make some money on it. And also the copyright does belong to the publisher, but they give me permission to use them in talks. So this is a nice example of a congenital nevus where the melanocytes track down around the adnexal structures and they trickle out into the dermis here. And here's an example of the melanocytes. See how they wrap around? They're wrapping around all these normal structures, like a little bit of erector pili here, a little nerve, a blood vessel. Totally normal to have them surrounding nerve. So don't let perineural growth worry you that something's malignant. There are plenty of benign things, particularly nerve sheath tumors and nevi, that can involve nerves and still be totally benign. And this is, I think, the best feature for congenital nevi is infiltration of erector pili muscle, like that. See how it's growing into? It's because as the way I conceptually think of it is the nevus grew in the baby as the skin was forming. Those melanocyte precursors, grew up into the skin and got tangled up into all the normal structures, which is why you find the nevus cells mixed in with the adnexa and the erector pili and everything. So that's a nice example. And sometimes the nevus cells can bulge into the lumen of dilated vessels and lymphatics and give the appearance of like lymphovascular invasion. I'm using air quotes here for invasion. That is a totally normal benign finding. Do not be afraid of that. Now, this is something that is a good thing for beginners to take note of, is that in nevi, particularly those big, thick congenital pattern nevi, you often get this compressed multinucleation of melanocytes, where the melanocyte nuclei clump together, and from low power, that can look really scary, right? It looks like big, huge, ugly pleomorphic cells, but when you go closer, look, they're actually nuclei that are just pushed together and overlapping each other. So there's not actual atypia here. This is just clustering of nuclei. It's just a trick, okay? Now, you also can have scattered large pleomorphic cells in otherwise benign congenital nevi. In fact, I see that often. Like if you look right here, maybe you can see it from here. See that nucleus? It's not like super ugly, but it's a lot bigger than its neighbors. It's 2 or 3 times the size of some of the other melanocytes. If you put some cells like that into a dysplastic nevus or something like that, then you might get scared, or into a junctional lesion on an old sun-damaged person's skin. But here in the setting of an otherwise perfect congenital nevus, no problem at all. So the context of findings matters a lot. I mean, this is always true in pathology, right? That when we see a feature, you have to take it in the context of the whole lesion and in the clinical context too. But just like you can see occasional mitoses in otherwise totally normal benign nevi. So don't let that worry you. And then some congenital pattern nevi can produce this epidermal kind of overgrowth. And sometimes it can have a horn pseudocyst and really closely mimic seborrheic keratosis. And also you can have overgrowth of sebaceous glands and hair follicles. So it's kind of like almost an induction type phenomenon where the nevus cells somehow are making the epidermis grow along with it. And some people use the term Unna's nevus after a famous dermatologist who lived in the 1800s. Unna's nevus to describe these lesions that have this kind of papillomatous surface that looks kind of like seborrheic keratosis-like. I personally don't usually use those eponyms in reports, but just so you know, Unna's nevus and Meissner's nevus for the kind of smooth dome-shaped ones are terms that some people use. I usually just call this benign melanocytic nevus, congenital pattern. Because we don't really know. I don't know for sure if that was present when the person was a baby or not. It probably was, but I don't always have that history. So I just say congenital pattern or with congenital features, something like that. And then here's another thing that's kind of a curiosity is sometimes you can get fat cells way up here in the dermis in the midst of a nevus. Like the nevus is like growing some fat with it. I don't know if it's fully understood why that happens. It's just kind of an interesting curiosity. And also take a look at these little cute things here. These, does this remind you of anything? Yes, good job. Meissner corpuscles. Who said that? Yeah, oh, I can't see who you is. Is it Drew? Drew, good job, Drew. Yes, Meissner's corpuscles. They look like the little swirled, to me, kind of like striped pink Easter eggs, or like swirls of cotton candy, whatever you're into. And normally they are would be right here in the papillary dermis on the volar surface of your palm and sole skin, like your acral skin, the fine touch receptors, right? But you can get them in two other main settings. You can see them in neurofibroma, diffuse type neurofibromas, and also in neurotized congenital pattern nevi. And so this is a nice feature that you can see. And sometimes I think people also in the setting of when they occur in neurotized congenital pattern nevi, sometimes people call them tactoid bodies, I believe, or Masson bodies. I learned that on Twitter from my friend Miguel Reyes Mujica, who's a pediatric pathologist in Pittsburgh, really great guy. And I thought, you know, Masson contributed a lot to pathology, but I think he's got his name on a few too many things. You should get like one eponym that you get to pick at the end of your life, and then the rest of the stuff gets renamed, okay? That's the rule if I was in charge. Oh, look at that. If you don't like that, I can't help you. That's the coolest looking thing. Look at this little stripes. It's so awesome. It's like it's almost like these are, to me, they're almost like a swirled, rounded kind of varicose body a little bit. Maybe that's a little too ethereal. I don't know, but it's kind of what they remind me of sometimes. And this is another feature that we see commonly. We don't always talk about it, but this is kind of the pseudovascular change where the nevus cells fall apart, and sometimes it can be so dramatic that it really looks a lot like a weird vascular lesion or something. But vascular lesions, normal ones, don't have little tufts of papillary stuff in the middle, right? There are some things like Dabska tumor, ultra rare things like that that can have papillations, but normally vessels don't have complex linings like this, right? And also in the background, even when this is extensive, you'll find other areas, like essentially always, other areas that look like regular nevus, okay? So this is a pseudovascular change, which I don't even mention. It's just kind of a cool thing. And see here, it looks more like regular nevus. All right, so now we've talked about some nevus subtypes. This is one of the scary pitfalls. So nevoid melanoma. Well, what defines nevoid melanoma? You can think about it different ways. My friend and mentor, Dr. Philip McKee, he's been an online mentor to me, and now over the past few years, I've gotten to know him, become friends with him and his awesome wife, Grace, and they're just wonderful people. You should go check out his Facebook group, McKee Derm. It's a fantastic place where he posts all the time, and you can learn directly from the master. It's so awesome. In any case, Philip likes to say, a nevoid melanoma is a melanoma that you called a nevus and wish you wouldn't have done, or something to that effect, which is a kind of scary but also pretty poignant way to say it. It's a melanoma that has features that resemble nevus. Now, one person may say, oh, I think this is nevoid or looks nevus-like, and other people may say, that's not nevoid. And it's not a specific, for treatment purposes, doesn't matter. It's a thing for pathologists to know about, that sometimes from low power, nevoid melanomas can have this appearance of nesting and maturation that makes you think it's a nevus, but when you go closer, you see ugly, obvious atypical cells. And also you can see there's some in situ component here, but from lower power, it can be harder to discern, okay? And one clue that another mentor of mine, Hafiz Dewan in Houston, Texas, he likes to say that this is called the puffy shirt sign. It's a reference to a Seinfeld episode where Seinfeld had a shirt that had lots of puffy frills on it, and it was just like too much and it was too busy. So all the nests are packed really close and tight together, and they're not spaced out. They're like lots of nests crunched together in the dermis. So all of these things can be subtle. The main thing to me is when you go closer at high power, whoa, super ugly usually. So that's why usually when I see nevi, I like to go and just take a look at higher power to make sure that even though I make the decision, I try to always make the decision from low power. Do I think this is nevus or melanoma, or maybe I don't know? Then I go closer to be sure that I'm right, okay? and study the lesion and make sure I'm not overlooking anything. But I think the key to benign versus malignant is it starts at low power, okay? Really important. Don't jump straight to high power on melanocytic lesions. It's a good general rule for pathology. Start at low power, figure out what you think it is, then go closer to confirm your low power suspicion. Big nucleoli, mitoses, ugliness, right? I find, especially when if you think it's kind of nevus looking and you start seeing big nucleoli down in the very deep bottom part of the dermal aspect of the lesion, that to me starts worrying me for maybe a nevoid melanoma, and I look closer at the lesion. All right, talk about recurrent nevus. Now, recurrent nevus is a scary thing because it's in the past, people have sometimes called it pseudomelanoma. Of course, I never put that in my report, but I think it's useful term for people learning dermpath to know about, because it's basically telling you this is a benign thing that's mimicking melanoma. And look at this. You've got a pagetoid cell here. You've got trickly growth of kind of nests and single cells along the basal layer of the epidermis that are starting to look like it could be confluent. There's a nest of this kind of grayish brown cytoplasm, which you can see in benign nevi, but you tend to get this cytoplasm in dysplastic nevi and also in melanomas. So when I see a lot of that cytoplasm, I tend to look closer at a lesion. By itself, that's not a malignant feature, but it's a feature that I do often see in atypical or malignant melanocytic lesions. So it's kind of a flag when I see that. So here you could look at all this and say, ooh, maybe it's a melanoma, but look, there's scar in the dermis. Okay, and look right here. Here's a couple nests of what looks more like a regular nevus. Now, I'm showing you close up, and this helps prove my point that looking at something way up close is dangerous sometimes. Because here, as we go out further and look at lower power, well, yes, that still looks atypical up here, but you can definitely see a big zone of scar here. And right next to it, what do we have? This is not recurrent nevus here. This is residual nevus. This is nevus left over after a previous, I think it was probably a punch biopsy they did, or a little excision. Some nevus was left over. And then the nevus started to grow back over the scar. And when it grows back in the epidermis over the scar, there's usually atrophic epidermis without much rete. The melanocytes grow back and look atypical, and they can have pagetoid spread, and they can have confluence. But the area of atypia is directly over the scar, okay? And doesn't extend out into the normal skin beyond the edge of the scar. So that's the key, is seeing the low power, and knowing the history that there was a nevus removed or biopsied at this site before. And if you're lucky, you'll get to see residual benign, obvious benign nevus left over. You don't always get that feature, but when you do. So in the history here is usually going to be, this is a patient that had a biopsy, a shave biopsy or an excision, something of a nevus a year or so ago, and now they're getting recurrent pigment in the middle of the scar. But sometimes you don't get, that history is not given to you, but that's the kind of classic history that you'd like to have. And then, oh yeah, I guess I didn't put the lower power in, but ideally I want to be able to see see all of the atypia and see the edges. So if I have a lesion like this and I can't see the periphery, if I have an obvious one where I know that there was a benign nevus before, I have the atypical stuff is confined over the scar and I can see normal skin at the edges. And even better, if I can see the residual benign nevus. If I have all of that, then I'll just say this is a residual and recurrent benign nevus with scar. And I'll just say it's benign. If I have this atypical stuff and some scar, but I can't see the edge, or I don't have benign nevus under it, or I don't have a clear history or the previous pathology available to review in my laboratory, then in those cases, I'm a little more hedgy, and I'll say something like it's a atypical melanocytic proliferation or a recurrent melanocytic proliferation, and it could represent a recurrent nevus, but I don't have any available history of a biopsy at the site, and we need to see if we can track down any previous pathology from an outside institution, ask the patient if they've had a biopsy there. And as you guys know, sometimes patients forget. They don't remember, or they maybe had a biopsy, but they don't remember what the diagnosis was. They just know the doc said it wasn't cancer, or they said it was somewhere on my back, but they don't remember exactly where. So I've seen many times like that where we were not able to get a clear answer. So in those cases, I say, well, it could be a recurrent nevus, but I'm not sure, and I'd like them to excise it and make sure that the margins are negative. So that's kind of how I handle that in real life, okay? Oh, here I did have the lower power. See, this is the perfect, this is as good as it gets. You're rarely going to get to see it this nice, but here you've got the residual zone of benign, obvious congenital pattern nevus down here. Then you can see the dermal scar. See how different the collagen pattern is? Collagen's packed closely together. It's a little more cellular with the fibroblasts. than the regular dermis, and we've got some prominent vesicles that are kind of pointing vertically, right? All the features of scar. Now remember that regression of a melanoma can sometimes have a lot of overlapping features with scar and can be a little bit challenging. Usually I feel like scar is much more organized, kind of horizontally organized, collagen and fibroblasts that run parallel to the epidermis, and then vessels that go vertically. And regression in a melanoma tends to be more disorganized with a lot of inflammation and pigment incontinence, and is more patchy. But I have seen times where regression looked very much like a scar, and only with figuring out the history we were able to tell, oh, this is actually regression. So it can be challenging sometimes, okay? But here, this had been shaved and the lesion grew back, and look how dark. It's very darkly pigmented. It kind of can look like a lentigo sometimes, and then there'll be nests a lot of times, and again, pagetoid spread. The first place when a nevus recurs, I feel like it tends to have recurrent growth in the epidermis, and then over time it seems like it can grow down into the dermis, and you can get some atypical hyperpigmented looking nests embedded in the scar. But the earliest stage, to me, from my experience, seems to be that it's the epidermal component, the intraepidermal component grows back, and then only later do you tend to get these nests in the dermis. All right. Lentigo. So lentigo, there's kind of two main types of lentigo, right? Lentigo simplex and solar lentigo. These are thought to be different in their etiology or their biology, but they can look very similar, okay? The lentigo has hyperpigmented keratinocytes, okay, along the basal layer. So this is one of my favorite pictures. I took this with my old iPhone 6. And just by holding it up to the ocular, isn't that amazing, the quality? I mean, I know I'm a little biased because I took it, but like, wow, I still can't get over this picture. But the key is this is also a really nice way to tell, look at the difference between melanocytes and keratinocytes. The brown cells with these little umbrellas of pigment over their nucleus, shielding them from the harmful rays of the sun, those are keratinocytes, not melanocytes, okay? Usually if you see a pigmented cell in the epidermis, it's going to be a keratinocyte, not a melanocyte. There are exceptions. Some types of nevi and some types of melanoma can get hyperpigmented melanocytes, but most often the melanocytes are going to be like this. These little guys with the kind of pale gray or pink cytoplasm and no pigment or very little spots of pigment, that is actually those are actually the melanocytes here. So those round cells there, see their nuclei look a little different too. Sometimes they'll look a little darker nuclei than the keratinocytes. Those are actually the melanocytes. Melanocytes make the melanin, and then through their dendritic processes, they feed it to the neighboring keratinocytes, which then kind of eat those little processes and store all the melanin and hoard it in their cytoplasm to make a little protective barrier against the solar radiation. So back to lentigo. Lentigo simplex has elongated rete with pigment in the keratinocytes and an increased number of single melanocytes. So there's more melanocytes here than in normal skin, but they're mostly on the sides and the tips of the rete and not really as much in between on the interrete space, and not with pagetoid spread. And usually, if you've just got this pattern with solitary melanocytes, then you can say that it's a lentigo simplex. If you start seeing nests, then usually I'll call it a lentiginous nevus or a benign nevus lentiginous pattern. And those two things can have very close overlap and probably exist on a spectrum. So lentigo simplex is kind of thought to be like the very earliest subtle stage of an actual of a nevus, a junctional nevus, okay? So that's why you'll sometimes see things that look like lentigo. You cut a little deeper and then you'll find a nest, okay? So that's the way, and usually I feel like these are going to be on younger patients and not on sun-damaged skin. In practicality, the way I tell lentigo simplex from solar lentigo is if it looks like a lentigo and there's solar elastocysts under it, guess what? I call it solar lentigo. If there's not solar elastocysts, I call it lentigo simplex. If I can't decide, then I just say benign lentigo and I move on to the next case because it doesn't really matter, right? So now you know the inside secret, and the distinction does not matter for treatment purposes or patient care. And then, oh yeah, I said if you have pigmented cells in the epidermis, they're keratinocytes. When you have pigmented cells in the dermis, they're usually melanophages, not melanocytes. Again, there are some exceptions. There are some types of melanocytic lesion that are highly pigmented, but most of the time, the really, really dark brown cells are going to not be melanocytes, kind of paradoxically, right? Now here's a solar lentigo. They do look a little different. One of the things is that in solar lentigo, you tend to get not only elongated, reedy, but they kind of get this like little club or a little boot shape. Like, see, this one looks like Italy, and then this is like, I guess, kind of like Sicily if it was migrated down. Maybe that's a Malta. I don't know. I like geography, but I'm clearly not terribly good at it. So in any case, these long kind of boot shape or foot shaped or hockey stick shape, if you, in honor of my former fellow, Kate Campbell, who's Canadian. And so I like to say when she was my fellow, we would say hockey stick because in honor of Canada. And so the thing that to know about these though is that because they tend to like bulge at the bottom like this, when you cut them, you often get things that look like nests in the dermis. These are not melanocyte nests. These are little keratinocyte aggregates that are heavily pigmented, and they represent this. They're the same thing as these. They're just cut at an angle. So if we cut a little bit deeper into the block, you would see these connect up to the surface. Does that make sense? See how they're right on the same level as the tips of the other reedy. So for beginners, this often confuses people and they think this is nested melanocytic thing, and this is a sun-damaged skin. So you think those are nests and it's pigment, and the dermatologist usually biopsies a solar lentigo for the sake of ruling out melanoma in situ, lentigo maligna, which is actually just a form of melanoma in situ that clinically resembles lentigo. So all those things could lead you astray and make you make a misdiagnosis. So if you're having trouble, you can do a stain like SOX10 or MART1. I personally like SOX10 better because it's a nuclear marker. I think it's easier to read. And you'll see that you will have a little bit of increased melanocytes here as you do in chronically sun-damaged skin. But all of these cells here, most of them are going to be at least, are going to be keratin. So see, like if we stained it like that cell's a melanocyte, probably that guy there is like double nuclei melanocyte. And there would be some more, but most of these cells are keratinocytes. But if you're having trouble with practice, you can do this easily on H&E most of the time. But if you're having trouble, then you can add on the SOX10. All right. So I told you Lentiginous Nevus. I forgot I had this in here. Haven't looked at this PowerPoint for like a while now. So Lentiginous, see how this looks like a lentigo, right? It's got elongated reedy with pigment. Oh, let me go back. I'm sorry. One thing I forgot to mention, and I should have put a picture in, is that there are kind of two patterns of solar lentigo. There's this classic pattern with the hockey sticks, and Rapini says, another mentor of mine who I really like a lot, and has the best teaching pearls, said that these are dirty puppy dog feet, right? They're like a little dog has walked through mud and has like little dirty feet. So I always thought that was kind of a cute little analogy. And you can have pigment incontinence. So this classic form with the elongated reedy is the one that we always teach. But I would say that actually even more common than this in real life are atrophic solar lentigo. They're basically totally thin epidermis with minimal or no reedy, but hyperpigmentation of the basal layer keratinocytes. And if you look on excision specimens of say squamous cell carcinoma or basal cell or melanomas, just look at the background. Anytime you see sun damage, you will find those little thin pigmented atrophic form of solar lentigo all the time. Think about when you see someone with really badly sun damaged skin, an older person, and they have all those little sunspots. Well, those are all basically lentigos, right? Solar lentigines. That's the plural of lentigo, lentigines. And so a lot of those are going to actually be the really thin atrophic type. So just so you know that you don't have to have the long reedy. If you just cut these reedy out and just leave pigment in the basal keratinocytes and solar elastosis down here, I'll call that a solar lentigo. All right. So Lentiginous Nevus has that same pattern of elongated reedy, hyperpigmentation, just like a lentigo, but add in some little nests. Now, Lentiginous nevi looks scary when you first start. I remember seeing one of these as a junior resident, and it was a little more subtle than this, and I was like, I can't even tell that there's nests of melanocytes there. And I can never do derm path. Thankfully, I didn't give up, and I now realize that these are just tricky lesions for beginners. And the reason is that the nest, I mean, here you can see a nice nest because I carefully selected this photo for using in my book, so I picked the very best one. But in real life, looks, that's a nest right here. It's like 3 or 4 or 5 melanocytes. Here's a nest here. Here's one here. And I know you guys are like, really? But I promise you, from having looked at and stained these before, you will see that if you do a stain, there are little clusters of melanocytes down at the tips of the reedy, but they can be very vague and subtle and hard to sort out because they kind of are masked by this abundant melanin pigment in the keratinocytes, right? So because of that, all of the pigment makes it look very busy and scary. It also makes it a little harder to see through because there's pigment everywhere. So it's distracting to your eye, and it kind of obscures where the cells are. The other thing about them that's a little difficult is that a lot of times the melanocytes in this lentiginous form of nevus have kind of a little bit of an angulated kind of shape. Sometimes the nuclei can get a little stretched or a little triangle shaped. They often have vacuolation, more prominent vacuolation of the cytoplasm. Again, all those things can make them look kind of busier and scarier than they are. And we usually teach that nevi are mostly composed of nests in the epidermis, and that if you have a lot of single or solitary melanocytes, that's a concerning feature for melanoma, right? Because melanomas, you tend to start getting more and more single melanocytes, and then they spread along the basal layer, that's confluence, and they trickle upward in the epidermis, and that's called pagetoid spread. And I have a whole video about the basic features of melanoma that you can go check out on my YouTube channel if you want. But in any case, though, so because of that, these lesions are nevi that tend to have small nests plus a lot of single melanocytes. But the key in sorting these out from melanoma is that the melanocytes, the single melanocytes and the nests, they're all down the rete, right? If you draw a line across the top of the papillary dermis here, the vast majority of the melanocytes are going to be below that line, not above it, okay? If I start seeing a lot of melanocytes going up in between the rete or trickling up with pagetoid spread, that's when I start to get concerned about maybe a melanoma, okay? Now, it's as you can see in that video I was talking about, that's not always true. You can see pagetoid spread in irritated or excoriated nevi and some lentiginous, or I mean some confluent growth, all that. Now, so in any case, though, you can use stains if you have trouble with lesions like this. The other thing I'll point out is that there is a lot of overlap between this pattern of nevus and dysplastic nevus. Some people who really don't like the name dysplastic nevus, and I have to admit I'm not a huge fan, but I do use it just because that's what people in practice use. And I've got a short video about dysplastic nevus that kind of goes into a little bit of my views on it if you want. But in any case, though, there are some people that they refuse to use the term dysplastic nevus, and some of those people will call all of them lentiginous nevi because dysplastic nevus tends to have elongated rete. So to me, though, in a dysplastic nevus, I want to see actually some cytologic atypia in the melanocytes, and also usually you have bridging of nests across rete and that fibroplasia, but there can be a lot of overlap and a lot of things that I probably would call a lentiginous nevus, other people would call a mildly dysplastic nevus. Again, there's a lot of subjectivity here and variation in nomenclature, okay? The main thing, whatever name we call this, as long as it's end up getting called nevus and not melanoma, that's the most important thing, right? So that's the key, and that thing about the papillary dermis I learned from a really awesome derm path in Australia named Ben Wood. I think I learned that from him on Twitter, actually, that he said you draw this line across the top of the dermal papillae, and if the melanocytes are all down below it, then it's usually going to be a nevus, like a dysplastic nevus or some other form of nevus. That's a one reassuring point towards benign rather than melanoma. All right, so these lesions tend to be kind of flat, dark, and kind of hazy borders, and so clinically, so they can look a lot like a dysplastic nevus clinically too. And anytime you have a lot of pigment in the epidermis, whether it's a lentigo or a heavily pigmented nevus like this, you'll tend to get a lot of pigment incontinence and have melanophages in the dermis. So if you're just starting out, look at all this brown stuff here. Do not be afraid. All of those are histiocytes, I promise you. You can go do a SOX10 stain if you want to, but you'll see these are all going to be histiocytes that are filled with melanin, also known as melanophages. And there's a closer look at the subtle nests, and then the single melanocytes too. And here's another one. And again, look at all that busy basal pigment that looks kind of scary and looks very busy. And so again, when you start out, I definitely stained these a lot more often when I was new in practice, and now a lot less so because I've just, after seeing, hundreds and maybe probably thousands of them, you get more comfortable with the pattern, and oh, if I stain this, it's going to look like the last 100 ones I stained. And then that's kind of how you learn over time. All right. This is the one I see. I guess I should have reviewed this, but since I didn't know we were going to be doing this PowerPoint today, we'll just have to do it cold. This is a good example of the vacuolation that can really be prominent in lentiginous nevi and in sometimes in lentigo simplex. So these are like really vacuolated melanocytes, and it makes the nucleus look kind of stretched out and squished and maybe triangle shaped a little bit. So that can be kind of confusing. And also notice these guys with the green arrow, naked nucleus with a halo around it. Those are not melanocytes. Those are keratinocytes, right? Same thing here, keratinocyte, keratinocyte, keratinocyte. You don't need a stain. With practice, you see that naked naked and alone nucleus floating in the middle of a vacuole all alone. Its cytoplasm is all out at the edge because it's hooked onto its neighbor. See the desmosomes right there? Very subtle. But the cytoplasm, when the cells shrink during processing, the cytoplasm can't go anywhere because it's hooked up to the desmosomes. All that keratin filament, remember, connects the desmosomes, which connect to the desmosome on the next cell, which connects to the keratin filaments, and that's why the epidermis holds itself together. It's not just the desmosomes, it's the keratin molecules that bridge across the cytoplasm and hook onto those desmosomes. And so the cytoplasm basically cannot move. So when the cell shrinks, there's only one thing left to shrink, and that's the nucleus. And it shrinks away from the cytoplasm, and it gives you this naked look like this with a halo of a vacuole around it. Sometimes you also get a signet ring shape. So these guys look signet ring, and in this case they're melanocytes, but there are times where keratinocytes can give this kind of signet ring pattern, and I don't understand why it happens sometimes and not others. I still don't fully understand these artifacts. So in any case, though, with staining you can see, and I don't think I have a stain on this one, maybe I do. Oh, yeah, that's maybe not from this case, but a different one. Here's an example of a SOX 10 with the red chromogen. Very good. SOX is really good, actually. It's my favorite, and I don't get paid by anyone to sell socks or anything, just so you know. I find it useful. All right, see, look at that of the melanocytes. Even though there's a lot of single ones, they're all down the reedy, and not in between. Down here. And look, they may bridge across a little bit. Again, if you wanted to call it mildly dysplastic, okay, but I'm going to just call this a benign lentiginous nevus. All right, now let's talk about dysplastic nevus. So I guess I do have it in here. I'm going to show you some of the classic features of dysplastic nevus. The problem is that none of these things by themselves are totally defined dysplastic nevus. You can see bridging in like congenital nevi. You can see some of these features in other types of nevus, which is part of why there's been this argument that's been raging since I think before I was born, or when I was very young, at least, as I was a kid, and people have been fighting about dysplastic nevus since like the 80s at least. I think it was the 80s when this all started, so I guess I was born. But in any case, I'm going to teach you the classic features of dysplastic nevus now. You can go, in my book, I've got a page where I kind of summarize my views on it, and I cite some different sources, both people that are very big fans of dysplastic nevus and people who are really against it, and kind of to give you a chance to go read and get some different viewpoints and then decide what you think, okay? But again, I do use this term in practice because all of the dermatologists who I've worked with are familiar with it and know what to do with it. And people ask me, do you grade them? I do grade them. I still, this may not age well, but I still do grade them mild, moderate, and severe. I do think that grading of dysplastic nevi is very subjective and varies a lot from pathologist to pathologist, which is problematic. The new WHO has recommended that we call them low grade and high grade, put them into kind of a two-tier category. So basically stuff that we would probably call mild should probably just get called like lentiginous nevus. Things that we used to call maybe moderate should get called low grade, and things that are severe we would call high grade. And in practice, I do tend to try to put things either as mild or severe and avoid moderate, but sometimes I think things fall in the moderate category. Two-tier systems are awesome. The problem is that in practice, they are challenging because there are sometimes lesions that don't fall comfortably into the two boxes we make, right? So in any case, I do recognize that the WHO now, skin book says that we should do low and high. But again, the dermatologists who I have worked with have used a three-tier system for a long time, and I think that that's something where you have to kind of use the language that's understood by your dermatologist. So again, people may watch this video years from now and be like, oh, that Dr. Gardner is so out of date. And I totally understand, and I accept your criticism. Okay, so now that I've said that, because people ask a lot, and now I'm going to have it in a video, and people can come and watch it, and there will always be something that someone will disagree with about this talk, I guarantee you. So, let's talk about the lesions. These are, in my opinion, dysplastic nevi are usually thin lesions. I don't like to call things dysplastic nevus that go deep into the dermis or have that periadnexal or congenital pattern. Some people do. Some people will say dysplastic with congenital features. I was always taught that those are two separate kind of categories. So that's just the kind of the way I was trained. That one pearl that came from another mentor, Bruce Smoller, he said that these are east to west lesions. They run from east to west across the slide, not north to south. Like a congenital nevus goes down deep. It's a north-south lesion, and dysplastic nevi are east-west. And I thought that was a great little pearl. So they tend to be thin and kind of correspond to the flat kind of appearance they have clinically. They have nests down the tips of elongated reedy, often a good bit of pigment, and the nests tend to bridge from the tip of reedy to the tips of reedy, right? And then they get this pink fibroplasia around them, and they usually have a little bit of lymphocytes around the vessels, some pigment dropout, all of those things. Look, some more bridging over here. All right, so then the other feature, so we talked about bridging, I just showed you. We also like to talk about shouldering, okay? Shouldering means that if it's and this only works for compound dysplastic nevi, it means that the dermal component of the lesion is in the middle, but that the epidermal or junctional component extends out to the side, to the periphery, beyond where the dermal stuff ends. So the dermal stuff ends right here at this nest, but the junctional stuff continues nest, 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 on the shoulders, out the side. So if you hold your arms up, your shoulders extend out beyond your trunk, right, your chest. So that's kind of the idea of shouldering, all right? So, and again, you can see shouldering. I see shouldering in congenital nevi all the time, which is, again, why I don't call those dysplastic, because I think that's a fine feature for congenital nevi. Other people who have a different viewpoint think, oh, that's actually means there's dysplastic nevus component there in a congenital nevus. Again, it's just different schools of thought, okay? So shouldering can happen. And then here's, again, another example of bridging. And notice the gray, kind of that gray abundant cytoplasm, often with little powdery fine melanin pigment. Some people have likened this to dirty dishwater. Sometimes it has almost an olive green kind of color. That's another kind of buzzword people have used. I do feel like this kind of pigment texture and color is often seen in dysplastic nevi and also in melanomas, but you can see it in totally benign nevi too. So by itself, that's not a malignant feature, but it does make me scrutinize a lesion more closely when I see that, okay? And then look at the nice layering of this, what we call lamellar, kind of layered fibroplasia or concentric fibrosis that wraps around these bridges. I find that the bridging with the fibrosis to be a useful feature towards dysplastic nevus. And I think if you were gonna, and I've always avoided putting grading in videos because, again, I know it's very controversial, but based on like this picture here, I think probably I would have said, I would call it either a mild or a moderate, depending on how the whole lesion looked, okay? And so in any case, that's bridging and that's fibroplasia. And oh, look at that. So that's really good. This is like the textbook example, right? Perfect bridging of nests from reedy to reedy. Perfect fibroplasia wrapping around each of the little nests. It's really, really nice example of bridging and fibroplasia. And another closer look at the atypia there. And so some of the way that people have said this, and if you look in the WHO and in other sources, they have some criteria that you can use for deciding if it's a low grade or high grade, and how to judge the atypia based on the nuclear size compared to the size of spinous layer keratinocyte nuclei. I think in practice, honestly, a lot of times we kind of use a gestalt, kind of a you look at it and you make a judgment based on the overall appearance. At least a lot of times I judge them by a gestalt look. Remember really, really carefully that all the features we're talking about here, bridging, fibroplasia, shouldering, those are all features that help us tell dysplastic nevus from regular non-dysplastic nevus. They are not features by themselves. Those are not features of melanoma. I feel a lot of beginners get confused about that. They'll say, oh, I see bridging and shouldering. I think maybe it's melanoma. No. Those are features. You see something, you think it's a nevus, and then you see the bridging and the fibroplasia and some cytologic atypia. Then you say, oh, I think it's a dysplastic nevus, okay? So that's the key there. Now, how do we tell dysplastic nevus from melanoma? Well, I'm about to show you an example that's a scary one, but the main thing, again, is the same rule we use for lentiginous nevus. Look at where the melanocytes are. Most of them are nests, and most of them are down in the reedy tips or on the sides of reedy, not up here at the top, okay? If you see something that looks like dysplastic nevus, but then you see confluent growth in between reedy, or you see pagetoid spread, that's when you start getting concerned about maybe it's a melanoma arising in a dysplastic nevus, or maybe it's a melanoma that's mimicking dysplastic nevus, which definitely happens too. And for that matter, I will point out that even though dysplastic nevus can evolve and turn into melanoma, I have to say that I think, in my experience, the times I see melanoma arise from nevus, which I see on a regular basis, I feel most of the time I end up seeing melanoma grow out of totally benign nevi, not dysplastic nevi, kind of paradoxically, right? Which is kind of the point of why people take issue with dysplastic nevus is that dysplasia we think of as a kind of stepwise progression of atypical features that ends in malignancy, right? Like you think about like cervical dysplasia in the setting of high-risk HPV and how that can progress to squamous cell carcinoma. But that's not the way that dysplastic nevi seem to be, in my opinion. And there, again, there's a lot of controversy and argument over this. But I feel like most dysplastic nevi do not evolve into melanoma. I'm not convinced that dysplastic nevi by themselves have any higher risk of turning into melanoma than any other type of nevus. People that do have dysplastic nevi, particularly multiple dysplastic nevi, do seem to have a somewhat higher risk of developing melanoma de novo on their skin, though. And again, there's tons of research out there you can read on this and a lot of nuance to it, but that's kind of a simplified summary of some of the things that I think people like to talk about with dysplastic nevus. All right. Now, here's an example of melanoma that's mimicking a dysplastic nevus. And this is a really important thing to remember. If you think it looks like a dysplastic nevus, look, it's got nests, bridging, even some fibroplasia, but look at that solar elastosis. This is on the face of an old person or the scalp of an old person. Do not call it dysplastic nevus on the sun-damaged face or scalp of the elderly in general. I have done it. I do it with great trepidation and immunostains and showing my colleagues, and I still don't like it. But most of the time, if you call something dysplastic nevus and it's a big sun damage on the face or the scalp, you're going to usually be wrong. It's usually going to be a melanoma. I have seen that multiple times. Misdiagnosis, something called moderate or severe dysplastic on the nose of an 80-year-old. No freaking way, okay? It's not, and I know I'm being a little strong with my words here, but it's really important to remember this because it's a big mistake, all right? If I'm going to call something a dysplastic nevus on the face of an older person, I better be able to see the entire lesion. I'm going to do stains on it. I'll probably do PRAME and do SOX10 and deeper levels and show colleagues. And those are because most of the time, I feel like even in people that have dysplastic nevi and younger people, I don't feel like I often see dysplastic nevi on the face or the scalp. The ear, sometimes you see dysplastic nevi or nevi that look like dysplastic nevus. So ear is kind of a special site, right? It has unusual features in the nevi that grow there. But on face, skin or scalp skin, be very, very hesitant to make a diagnosis of dysplastic nevus, especially in old sun damaged people, okay? So here, this looks very nested. It looks like most of the melanocytes are down here. Look, there are lots of vacuoles, but those are all keratinocytes there, most of them at least. But maybe not that one. So this is a time where sometimes if you look elsewhere in the lesion or do stains, you'll see that even though there are nests and bridging, there's also a lot of single cells with interreedy growth and some pagetoid spread. Here's another area of the lesion. Look, we do have, there's a pagetoid cell up here, but more importantly, look at this. This is not dermal invasion. This is actually a sweat duct. You can see a little bit of the lumen there. You'll have to trust me. I promise it's there. But this is basically in situ melanoma, growing down and filling up the epithelium of the sweat duct. This is a Lentigo maligna pattern of melanoma, okay? And these are the ones, I feel like the Lentigo malignas are the ones I see most often mimicking dysplastic nevus, okay? And they tend to extend down adnexal structures. That's a really helpful clue. That can help. And again, doing stains a lot of times, see, I'm already seeing some extra single cells here in the interreedy space at the tops of the dermal papillae, and I'm also seeing some pagetoid. So when I don't think I ended up staining this one because there was no need to. I think with this, definitive melanoma to me. But in any case, though, I find a lot of times these look like a dysplastic at first, and then when you scrutinize it further, you're like, ooh, wow, there's actually a lot of pagetoid spread and confluent growth, and that can help you. So just remember that, Pearl. Now, Spitz nevus, okay, also known as epithelioid and spindle cell nevus because they tend to have epithelioid and spindled cells. This is another area that's very difficult and challenging, and what I usually recommend is if you're a general pathologist, not a dermatopathologist, I would avoid not making a diagnosis of Spitz nevus without a consultation because they can be pretty challenging and they can look really atypical. So sometimes benign ones can look scary and make you want to call them melanoma. And also there are melanomas that can mimic Spitz nevus or have Spitz features or evolve from Spitz background. And so all of this is very difficult, even for trained, experienced dermatopathologists. There's a lot of difficulty in this area. We show our colleagues all Spitzoid things that we encounter because even for trained people, it's difficult. So that's my disclaimer. But now I'm going to teach you some of the basics, okay? Again, these were thought a long time ago to be a melanoma in kids, but that had a good prognosis, and eventually they realized, oh, this behaves well, is the kind of very short version of that story. And they have abundant cytoplasm, large nuclei, and the nuclei tend to have prominent central nucleoli, all right, and then abundant pink or gray cytoplasm. But these large nuclei, kind of open, pale chromatin, and big central nucleoli, that's the classic nuclear feature. Now, I know some of the times melanomas have nuclei that look like this, which again is why it can be challenging. But recognize that this is kind of the classic spitzoid feature. When you see cells that look like this, stop and ask yourself, am I sure it's melanoma, or could it be a Spitz Nevus? You have to not just look at the cytology, you have to look at the whole architecture, right? Remember, in melanocytic lesions, architecture is the most important thing most of the time. Then you look at the cytology after that. Here's another example that's more elongated and spindled, and even when they're spindled, they're plump, kind of fat, juicy spindle cells that have a lot of cytoplasm and have kind of oval spindled nuclei, not thin little wispy spindle cells, okay? So these very plump spindle cells, the characteristic of Spitz, and again, look at the central nucleoli there. Now, Spitz Nevus can be purely junctional, or it can be purely intradermal, or it can be compound and have junctional and dermal components. All of those three are possibilities. It's nice when you have a junctional component, because oftentimes the junctional nests in Spitz nevi are big. You have large nests, and the nests tend to get this kind of cracking or clefting artifact where they separate away and make an empty space between the edge of the nest and the surrounding epidermis. So big nests with a bunch of cytoplasm, nucleoli, clefting artifact, all of that stuff is great for Spitz Nevus. And also look at these pink blobs right here. That is basement membrane material, collagen type 4, and those are called camino bodies, okay? So when you don't always have camino bodies in Spitz nevi, but you often will, and it's not 100% for a benign Spitz Nevus. You can, for a while people debated about that, and I think there was even some people that had monetary bets out that, you know, that they would say, I'll give you so many $1,000s if you show me a melanoma with a camino body. But I think those bets have gone away, which makes me think that, you know, someone showed someone a melanoma with a camino body. In any case, I find it nice and reassuring, but not proof of a benign Spitz Nevus, okay? But it is a nice feature that you should know about, is camino bodies. The other thing is people say is, and this only works again when you have a dermal component to your Spitz Nevus, is that they often have kind of a vaguely wedge shaped. And a wedge basically means upside down pyramid or pizza piece or whatever you want. I mean, this is like a big, massive piece of pizza. But if you use, and you have to kind of use your imagination here. I'm a very concrete thinker, not very good at abstract thought, I guess. That's what my psychiatrist wife says. And so this is not shaped like a wedge or triangle, so you have to kind of use your imagination. I want it to be like a perfect geometric shape, which is why I drew the line here. But if you look at it, the top of the lesion is wider, and it comes down to kind of a narrower, deep aspect, okay? So that's a typical feature we see in Spitz nevi, and some other things like deep penetrating nevus does the same thing. And see, even from here, look at those huge nests up here. And there's a nest there, and nice clefting. And also look at this one too. Look at how abruptly it stops. Right there is the edge of the lesion. It doesn't trickle out at the edge. It stops with a nest. Over on this side, not as discreet, but usually the Spitz nevus starts in a nest, and then at the other end, it ends in a nest. And again, I think probably due to the angle of cutting, we don't really see the other nest at the other end that well here. Oh, here's a better picture. Like, look, that's the edge of the lesion there. You don't have to wonder, well, where does it? Nope, it stops there, and over here it stops right there. And then you can, again, have some kind of bridging here. Bridging doesn't always mean dysplastic nevus, okay? And these are big nests again, abundant cytoplasm. You will sometimes see some pagetoid cells. I feel like oftentimes in Spitz nevus, the epidermis gets acanthotic, gets hypergranulosis. A lot of times it seems to have kind of some irritation changes to it. And you can have some inflammation, but you tend to get a lot of acanthosis and elongated rete that kind of grow along with the melanocytes as the lesion grows. All right? And here's an example of pagetoid spread in a Spitz nevus. And here's some more over here. Pagetoid, either single cells or nests. And then here's a nice example of camino body. And they can either be like actually embedded up in the epidermis or in the papillary dermis or right at the dermal epidermal junction. Usually that's where they're coming from, is the dermal epidermal junction, but depending on the angle of cut, it can look like it's way up in the epidermis here. See, that's actually dermal papilla right there. So see, it's coming right off of that, but sometimes it looks like they're floating in the epidermis because of the oblique or tangential nature of cutting through the tissue. All right. And again, there is a kind of a category in the middle where we call things atypical Spitz tumor or atypical spitzoid neoplasm. And when I have a Spitz nevus that is atypical or doesn't fit perfectly, and the older a person is, the more perfect I want a Spitz nevus to look to make that diagnosis outright. Those are the ones where we can really struggle, and in those cases, a lot of times I end up sending for molecular testing, and I think those can be very challenging. And some people really don't like that we use that intermediate category, but unfortunately, in these spitzoid lesions, when they get really atypical, it can be very difficult to determine whether they're going to behave well or not, based on purely on light microscopy. So H&E morphology is really great at a lot of things, but this is an area where it sometimes falls short. And even with the best of our expertise and efforts, it can be really difficult sometimes to predict the biologic behavior of spitzoid lesions when they have atypia. So that's kind of the basic thing I want to say about Spitz nevi, is that to remember that if it's a kid and it has perfect features, then fine, Spitz nevus. The older someone gets, the more I get worried if I see atypia out of the normal. And again, you could look at all of these cells here and say, that's atypical, that's atypical. So the atypia of Spitz nevi, all the cells look kind of atypical compared to normal other nevi, but they all look kind of similar in their atypia. If I start seeing really bizarre atypia, if I start seeing, so here, what are the features that concern me? I didn't really go into it here because this was a kind of basics talk, but I'll tell you, if they're an older person, the older they are, the more worried. I have made a diagnosis of Spitz nevi in people, in their 40s or even 50s, rarely, and then only a lot of times I'll want molecular testing to prove it, or it has to look absolutely perfect and I see the whole lesion on an excision, but I get very nervous about it. I regularly diagnose Spitz nevi in people in their 20s and even into their 30s. But the older someone gets, the more likely you are to be wrong. I think about this. And the other things are, so what are the features that worry me? If I see bizarre pleomorphism way beyond the atypia of the other cells, if I see a lot of dermal mitoses, if I see deep dermal mitoses down in the deep aspect, like down here, if I see mitoses, if I see atypical mitotic figures, like tripolar mitoses, things like that, those are all features that concern me a lot. And also if I see trickling growth out to the periphery, all of that stuff, those are the features that I worry the most about. And that's the time that I'm going to work a lesion up more with immunostains and or molecular, and also get consultation from my colleagues, and even send out for expert consult sometime. All right, so guys, I think, let me just show you blue nevus quickly, and then you can go to clinic, all right? So blue nevus, you have abundant melanin pigment in the dermis, some of which is in melanocytes, spindle melanocytes, and some of which are in melanophages. And also, notice this from low power. Here's your normal reticular dermal, the big thick collagen bundles. Look at this, though. This is very dense. You still have those thick collagen bundles, but it's kind of wrapped by really dense sclerotic collagen. Blue nevi usually have a lot of dense sclerotic collagen in the background. Sometimes it can be very abundant, and some people call those sclerotic blue nevus if you want. But I would say most blue nevi have some degree of dermal sclerosis. Blue nevi may be really tiny little things like this size, or they may be big lesions like this that go way down into the deep dermis and wrap around adnexal structures. And at the edges, they often entrap collagen. If you look closer, there you can see that here's collagen bundles, and that they are wrapped around by the blue nevus cells, okay? So if you did a stain, most of these elongated cells that have kind of pale cytoplasm, these are going to mostly be melanocytes. And then the ones with the big, dense, chunky pigment, those a lot are going to be melanophages, histiocytes, or macrophages that have eaten up melanin. But the collagen trapping in blue nevus can really be a close mimic of what you see in dermatofibroma. And dermatofibromas can have a lot of pigment too, but the difference is that in blue nevus, the pigment is melanin. In dermatofibromas, the pigment is hemosiderin from blood, okay? But when you have a blue nevus that's hypopigmented, that lacks melanin or has very little melanin, it can look very similar to dermatofibroma. Here's an example. I think this was from the middle of like a cellular blue nevus perhaps, but it's because it's a little more fascicular in the growth, but you can see again, these elongated spindle cells, most of those are going to be the melanocytes. These are the melanophages. The big chunky blobs of melanin are in the melanophages. And then here's that background sclerotic collagen. And here's an example of hypopigmented blue. Again, it can really look a lot like dermatofibroma because of the collagen trapping and the bland spindle cells. But one difference is that the epidermis over a dermatofibroma often has hyperplasia, acanthosis, flattening or blunting of the rete, and you don't usually see that over top of blue nevi, okay? And usually, even in the most hypopigmented of blue nevi, if I go looking closely, I usually will find some cells focally that have a little bit of melanin pigment. Like here, there's an example of the collagen trapping, very nice. And I don't remember if there was any in here, but usually if you look close, you can almost always find a little bit of melanin. Ah, there it is, yes. See, I promise you it's there. You just have to look for it a little more closely. So just know this, that hypopigmented blue can look like dermatofibroma, and for practical purposes, it doesn't really matter, right? They're both benign lesions, okay? And this is an example of cellular blue nevus, and I have a whole long video about this on my channel. They have, cellular blue looks scary because down at the bottom it has these bulging, dumbbell-shaped bulging protrusions pushing into the deep dermis or subcutis, and these areas are very cellular, they can be fascicular, the cells are a lot bigger and look kind of scary, but if you go up to the top and out to the periphery in the reticular dermis, you'll almost always find areas that look like classic, conventional, regular blue nevus. So cellular blue is important to know. It's a benign lesion, but it's important because it breaks the rule about maturation. This is a lesion that is more cellular deep down at the bottom than at the top. And at closer look here, you can sometimes see scattered mitoses. You don't want to see a lot, but seeing occasional mitotic figures, even in that deep aspect, is okay for cellular blue. But again, if you see a lot or if you see pleomorphism, then you got to start being careful because there are some melanomas that can mimic cellular blue nevus. And in those cases, molecular can be potentially helpful. And but most of the cells are very oval and uniform, and they run in fascicles. They usually have either no nucleoli or very small nucleoli. And again, this is the same case. Look up at the top and at the edge, collagen trapping. This is regular blue nevus, okay? So I think that's enough, and we'll stop there for today. And thank you guys very much, and have a great weekend.